My dear student, welcome on the pharmacology session, pharmacology multiple choice questions. And this is a fresh session. We're going to do 10 good questions of pharmacology, 5 options each, and we try to discuss each of the 5 options so that you get a broad view of the question. Question number 1. Here's your question on your slide. Have a look at the slide. Which of the following is an osmotic laxative? A. Dietary fiber. B. Liquid paraffin. In the parenthesis, a mineral oil. C. Magnesium sulfate. D. Castor oil. And E. Docusades. So we have 5 options here, and there are drugs from various groups. We need a drug which is going to act by osmotic effect, and the drugs which are likely to produce osmotic effect are likely to be alkalis. You can address this question this way and have a look at the options. No harm. Dietary fiber. Fiber is going to increase the bulk in the gastrointestinal tract, so it's not osmotic effect. Next one is liquid paraffin or mineral oil. I hope you know liquid paraffin. It produces soothing in the intestinal tract. It's going to produce what is called emollient effect. That's called soothing effect, so that the stool is passed without straining. So is it osmotic? No, it's called emollient. Next you have magnesium sulfate. Magnesium sulfate is an alkali, and let's keep it for some time. Next is castor oil. Castor oil is an age-old purgative, and which is a very strong purgative, and it produces mechanical irritation. So I hope you know it's called irritant purgative or stimulant purgative. So again, it's not osmotic. And the last one is docusades. Docusades is specifically stool softener, so it's softening effect. So you don't have anything else to choose other than the one which we kept aside, magnesium sulfate. Yes, these drugs are acting by osmotic effect, and by the osmotic effect they increase the water content in the intestinal lumen, and this is going to move the bowel, and this is going to produce laxative effect. Just for your information, the words laxative, purgative are many times used synonymously, and someone might say laxative is different and purgative is different, but if you think of the quantitative effect and the quality of the effect, laxative in general has a mild action and purgative in general has a strong action. So osmotic purgative or osmotic laxative is magnesium sulfate. I hope it was quite clear. Let's go to the next slide and check our answer right. That's magnesium sulfate. Question number 2. Acetazolamide is useful in the management of heart failure, myocardial infarction, hypertensive crisis, acute mountain sickness, and nephrotic edema. Acetazolamide. Acetazolamide is a carbonic anhydrase inhibitor. It affects the bicarbonate concentration, and this is not a strong diuretic, it's a weak diuretic, but because it affects the bicarbonate concentration, many users come for acetazolamide. Since it's a weak diuretic, you may not think of using it for heart failure, for myocardial infarction, for hypertensive crisis. All the things, 3 things are already out. Next is acute mountain sickness, and the next one is nephrotic edema. So nephrotic edema, again you need a diuretic which is potent. You can think of the high ceiling diuretic, that's loop diuretics. In certain situations you can think of thiazide diuretics. Acetazolamide is a weak diuretic. This is not going to come to help. So probably we are waiting on the option acute mountain sickness, and if you remember I said about the bicarbonate concentration. So it's about the hypoxia, is about the tissue hypoxia, and acetazolamide is useful in many conditions because of this effect on the bicarbonate. For example, let's think of glaucoma, in which the aqueous humor secretion can be affected because it decreases the bicarbonate. It can decrease the aqueous humor formation. Sometimes the bicarbonate ion is responsible in some epilepsies. So you can think of using acetazolamide in some epilepsies, and this is a very specific effect. There are not too many drugs for prevention of acute mountain sickness. Let's see the answer. Acetazolamide acute mountain sickness. Please remember, it's a specific use of a carbonic anhydrase inhibitor. Let's go to the next slide. That's the third question. Question number 3. Alcohol should not be consumed while receiving treatment with streptomycin, cefaclor, doxycycline, amoxicillin, and cloxacillin. It means if the patient is on any of these drugs and the patient consumes alcohol, the patient is going to get alcohol intolerance. What could be the cause of this? The cause of this is some of the drugs act like disulfiram. What is disulfiram? Disulfiram is aversive therapy used for management of alcohol addiction. And I think let's do some work here. We are speaking about methyl alcohol. I will try to write it. I am not writing ethyl, please presume it's ethyl alcohol is metabolized by the dehydrogenase enzyme. That's alcohol dehydrogenase is going to get converted into acetaldehyde. This acetaldehyde will be again acted upon by the same species of enzyme, that's dehydrogenase. That's acetaldehyde dehydrogenase, and you get formation of acetic acid and water. So that's acetic acid and water. So what I was saying, the drug disulfiram produces its specific effect in this alcohol metabolism, and disulfiram acts here. So that's, I'm showing the sign of inhibition, acetaldehyde to acetic acid. I'll put here disulfiram. What's the result of this? If a patient has taken disulfiram and if the patient consumes alcohol, disulfiram is going to stop it at the level of acetaldehyde, and the acetaldehyde is going to accumulate and the patient gets a severe reaction, and you call it alcohol intolerance. And this is used as aversive therapy in the management of alcohol addiction. The issue is, the problem is, many of the drugs have got the same effect like disulfiram. So if you take these drugs, same thing is going to happen as it happens after consumption of disulfiram, that the patient is going to get acetaldehyde toxicity. Which drug out of the following? If you look at the drugs, there's only one drug. It's called cefaclor. It's a cephalosporin. Cephalosporins are known to have disulfiram-like effect. Just to complete the discussion, few more drugs which can do it is metronidazole, tinidazole, cimetidine, ranitidine can do it. So please remember, if the patient is on cephalosporin, please instruct your patient not to consume alcohol. Alcohol should not be consumed while receiving treatment with cefaclor or cephalosporins. So that was question number 3. Now we start with question number 4. Here's your question on your slide. Which of the following is most likely to produce extrapyramidal reactions? Options: enalapril, methyl dopa, metoprolol, hydrochlorothiazide, and nifedipine. Are you thinking? Extrapyramidal reactions. Do you remember any disease in which you call it extrapyramidal reactions? A simple statement: Parkinson disease. Then you think, what's the reason of the extrapyramidal reactions? It's something concerned with dopamine. There will be dopamine deficiency, there will be decreased dopaminergic transmission, or there will be blockade of the dopaminergic receptors. Any of these things can happen. So do you have any drug on this particular list which can do it, which is going to decrease the sympathetic activity? Enalapril, does it affect the sympathetic activity? No. Methyl dopa, dopamine, is it related? Yes, it seems to be related, because you have to have the same structure to produce the action. So let's keep methyl dopa aside. Metoprolol, a beta blocker, can it produce an effect in the central nervous system so that the dopaminergic transmission can be blocked? Metoprolol. Propranolol, metoprolol, have you heard they produce extrapyramidal reactions? No. Hydrochlorothiazide is a thiazide diuretic, in no way is related with extrapyramidal reactions. And the next one is nifedipine. You need not choose nifedipine and enalapril. In fact, one is calcium channel blocker and one is ACE inhibitors. Their adverse effects are totally different kind of adverse effects. We waited for some time at methyl dopa, and this seems to be the answer. This seems to be the right answer. Methyl dopa is an antihypertensive agent, and this agent is supposed to act on the presynaptic alpha-2 receptors in the central nervous system, and it's an agonist of the presynaptic alpha-2 receptor. Interesting thing is, this drug is agonist, but it leads to fall in the blood pressure. What's the reason? Because the presynaptic alpha-2 receptor in the brain is an inhibitory receptor, and when you go here and stimulate the receptor, there is decrease in the sympathetic activity. So that's the mechanism. Whatever happens in hypertension, the same thing is going to happen. The dopaminergic outflow is going to decrease, the dopaminergic transmission is going to be decreased, and the drug can lead to extrapyramidal reactions. Please remember methyl dopa. Another friend of methyl dopa in the same group is clonidine. So clonidine and methyl dopa, both of them centrally acting antihypertensive drugs. They are likely to produce extrapyramidal reactions. That's your answer on the slide. Methyl dopa, that's correct. Next question on your slide, question number 5. Which adverse effect of aspirin is related to increased leukotrienes? Let me just give you a picture. Arachidonic acid metabolism. It goes in two pathways. One is called cyclooxygenase pathway and the second one is called lipoxygenase pathway. Cyclooxygenase pathway mainly leads to prostaglandin synthesis and the lipoxygenase pathway leads to the leukotriene synthesis. Enzyme there is 5-lipoxygenase that leads to synthesis of various leukotrienes and the leukotrienes act on the leukotriene receptors. So that's about the arachidonic acid metabolism. What is aspirin? NSAID. It blocks the cyclooxygenase. The question the examiner is asking you is which adverse effect of aspirin is related to increased leukotrienes, because the logic is if you block the enzyme cyclooxygenase, arachidonic acid is going to get diverted to the other pathway and then the leukotriene synthesis is going to increase, and that's why the question which adverse effect is related to leukotriene synthesis. Let's go to the options. Stevens-Johnson syndrome, precipitation of bronchial asthma, internal bleeding, renal damage and peptic ulcer. Stevens-Johnson syndrome is a hypersensitivity reaction. It's a hypersensitivity reaction. It's nothing to do with the dose related adverse effects. Next is precipitation of bronchial asthma. You inhibit the prostaglandin synthesis and the arachidonic acid is diverted to the lipoxygenase pathway. Leukotrienes are synthesized. Leukotrienes are potent bronchoconstrictors and they are important agents in bronchial asthma. So precipitation of bronchial asthma can be the answer. Next one is internal bleeding. This internal bleeding is happening due to another mechanism, that low dose aspirin is going to inhibit thromboxane A2 synthesis, and if that effect happens excess is going to be internal bleeding, nothing to do with leukotrienes. Renal damage. Renal damage takes place because aspirin also inhibits the renal prostaglandin synthesis, and so many homeostatic mechanisms in the kidneys are disturbed and it leads to renal damage. So it is related to prostaglandin synthesis inhibition, not exactly leukotriene synthesis. Last one is peptic ulcer. Is the same. Aspirin is non-selective, so it is going to inhibit cyclooxygenase of both the types, COX-1 and COX-2. And when you inhibit the COX-2 cyclooxygenase 1, prostaglandin synthesis in the stomach is going to come down, and prostaglandins in the stomach are cytoprotective. So this cytoprotection is gone and the patient becomes more susceptible to peptic ulcer. So peptic ulcer related to inhibition of prostaglandin synthesis. So I think we've almost resolved and we have ruled out internal bleeding, renal damage, peptic ulcer and Stevens-Johnson syndrome. Please remember, aspirin is a drug which can precipitate bronchial asthma. Many non-steroidal anti-inflammatory drugs, they can precipitate bronchial asthma. Is the same mechanism, is activation of the leukotriene synthesis. I hope this was nice and you could revise the prostaglandin synthesis and the leukotriene synthesis. And then let me complete, because leukotrienes are the substances involved in bronchial asthma. We got new drugs for bronchial asthma. 5-lipoxygenase inhibitor which decreases the synthesis of leukotrienes, that's xylutol. And when leukotrienes are synthesized and they act on the leukotriene receptor, you have leukotriene receptor antagonist, zafirleucast and monteleucast. I hope you'll remember this. That's precipitation of bronchial asthma. Slide number 5, that's the answer. Question 6. Overdose by a weak base is treated with administration of. If you get a poisoning, if you get an overdose, toxicity with a weak base, let's imagine a weak base, like a drug like amphetamine, say weak base. So how to treat it? Options: naloxone, ammonium chloride, physostigmine, sodium bicarbonate and aluminium hydroxide. Now if you look at these options, naloxone is something which is a morphine antagonist, so you cannot generalize naloxone for this, and physostigmine also is an anticholinesterase agent, you cannot generalize it for all the poisoning, so we'll remove naloxone and physostigmine. Next one is sodium bicarbonate. Oh, it's an alkali, We are speaking about overdose by an alkali. Obviously it will be out. And the last one, aluminium hydroxide. No doubt it's an alkali, but that's not the reason. The reason is aluminium hydroxide is not absorbed. So it's not going to be useful for any systemic effect. So that's gone. And by omission we came to ammonium chloride. Ammonium chloride is an acidifying agent. And when you get the poisoning or toxicity by weak base, what will be the purpose of the management? The purpose of management is to remove this substance out. If you want to remove a substance out of the body, the substance should be ionized or non-ionized. If a substance is non-ionized, it's going to be reabsorbed. So you want to produce ionization. And if you want to produce ionization of a base, you need to give a substance which is acidic in nature. And this is why whenever you have weak base poisoning, alkali poisoning, we go for an acid, and that's ammonium chloride. Let's check. Yes, it's ammonium chloride. Let me tell you something. If it's opposite, if the poisoning due to weak acid, like salicylate, salicylic acid, barbituric acid, if it's acidic poisoning, you always treat it by alkalinization. So in those situations you give sodium bicarbonate, same principle. So weak base overdose, ammonium chloride. Let's go to next question. You ready? Question number 7. Which of the following is increased by atropine? Now I'll take the name of the option and you think and you say to yourself yes or no. Which of the following is increased by atropine? Salivary secretions? Increased by atropine? No. Atropine produces dryness. So it's gone. Tone in the intestinal smooth muscle. Is it increased by atropine? Atropine is an antimuscarinic agent, anticholinergic agent. And we always call atropine as antispasmodic. So it's going to relax. So tone in the smooth muscle is going to decrease. So that's not the answer. Conduction across AV node. Atrioventricular conduction. Is it increased by atropine? Yes. Atropine increases AV conduction, and that's the reason why we give atropine as pre-anesthetic medication, because it can prevent bradycardia by increasing the AV conduction. Any reflex vehicle bradycardia can be prevented if atropine is present as a pre-anesthetic medication. Conduction across AV node seems to be the answer. Let's confirm. Bronchial secretions. Does it increase the bronchial secretions? No. We already discussed it reduces all the secretions. Last one is tone in the urinary tract. It's also decreased. It's intestinal tract, the respiratory tract, urinary tract, everywhere it's antispasmodic effect in the smooth muscle. So the answer for this question is conduction across AV node is increased by atropine. Atropine is extremely useful in pre-anesthetic medication. It's also useful when there is digitalis toxicity, and the earliest sign of digitalis toxicity is bradycardia, sinus bradycardia. So if the heart rate starts going down, you give atropine. So that's atropine. Another use is digitalis induced AV block. Drug of choice is atropine. So now it will be confirmed. Atropine increases the AV conduction. That's why it's useful in management of AV block. So that was your question 7. Let's go to the next question. That's your answer. Conduction across AV node. Question 8. Indinavir has which specific adverse effect? Indinavir, I hope you remember our discussion. Navirs are protease inhibitors. And characteristic toxicity of protease inhibitors is disturbance of lipid metabolism and glucose metabolism. So there's hyperlipidemia, there's hypercholesterolemia, there is redistribution of fat, and in glucose metabolism, they produce glucose intolerance, they can produce hyperglycemia, they can worsen diabetes. These are common adverse effects to the protease inhibitors. As far as the specific adverse effects are concerned, we have pancreatitis, nephrolithiasis, hepatic damage, paresthesia, and joint pains. So let's go to the answer. Nephrolithiasis is a specific adverse effect for indinavir. Next we go to question number 9. Respiratory paralysis due to competitive neuromuscular blocker is rapidly reversed by using what? We read the question again. Respiratory paralysis due to a competitive blocker, neuromuscular blocker, is rapidly reversed by using. It means you give a competitive neuromuscular blocker, means a skeletal muscle relaxant, a nicotinic blocker. And if you have given it, and due to it there is respiratory paralysis because there are skeletal muscles of respiration. If they are paralyzed and you want to rapidly reverse it, what to use? It means, in other words, nicotinic receptor is blocked. Cholinergic nicotinic receptor is blocked. You have to revive the receptor. What are we going to use? In my opinion, by logical thinking, the answer of this question should be acetylcholine, because it's a cholinergic receptor and the nicotinic blocker has blocked it. You should give acetylcholine. Well, you can't give acetylcholine. It's not practically possible. Give something like acetylcholine. And with this thought in mind, let's read the options. A is artificial respiration. Yes, artificial respiration could be useful, but it cannot reverse the competitive neuromuscular blockade. Next is hydrophonium. Hydrophonium is an anticholinesterase agent. It is rapidly acting. You understand what anticholinesterase is. He is going to concentrate acetylcholine. It's going to potentiate acetylcholine. So it will pour acetylcholine at the nicotinic receptor. This acetylcholine can produce antagonism and can remove the antagonist from the nicotinic receptor. Hydrophonium can be the answer. Next one is atropine. What's atropine? Atropine is a muscarinic blocker, not connected to this question. We are thinking about right side, nicotinic side. Atropine is muscarinic blocker. Next is D-tubocurarine. Oh, D-tubocurarine itself is a neuromuscular blocker. Obviously not. And next one is physostigmine, which is also having same action as hydrophonium. So you can choose between hydrophonium and physostigmine. It's also an anticholinesterase agent. Now if you look at these two drugs, there are one or two differences between them. Hydrophonium is rapidly acting. That's one. And I think let's read the stem again. Respiratory paralysis due to competitive neuromuscular blocker is rapidly reversed by. The examiner is interested in rapid reversal. So that's one reason we can go for hydrophonium. Second reason is physostigmine is an anticholinesterase agent, but neostigmine, hydrophonium, pyridostigmine, they have got a specific effect on the skeletal muscle, and that's a direct agonistic effect. They are anticholinesterase. In addition, these drugs have got a direct agonistic effect, so they can work like acetylcholine and they can revive the receptor, they can displace the antagonist. So that's another reason. So there are two reasons for us to prefer hydrophonium, which is the short acting agent. So let's confirm the answer. Yes, hydrophonium. Go to the next question. That's the last question, question number 10. A patient with peptic ulcer disease receives ranitidine and sucralfate. What is the most likely outcome? Ranitidine is an H2 blocker. Sucralfate is ulcer protective drug. And what is the most likely outcome? A. Ranitidine increases the toxicity of sucralfate. Ranitidine inhibits the action of sucralfate. Sucralfate increases the toxicity of ranitidine. Oh, it's a great twist. And sucralfate inhibits the action of ranitidine. And the last one is both inactivate each other. You cannot solve this question this way by getting tangled into these twists. It's better to know about it. Sucralfate is an ulcer protective drug. To produce its action, it has to get polymerized. And the polymerization of sucralfate depends on the pH of the stomach. If the pH is acidic, this process is fast. If it's difficult for you, I could simply say sucralfate needs to get active to produce its action, and this can only happen at a low pH. If its acidic pH is going to happen. And ranitidine is an H2 blocker, so it's going to decrease the gastric acid secretion. This can raise the intragastric pH, and if the pH is little more, then sucralfate cannot produce its action. So ranitidine and sucralfate present at the same time in the stomach. Ranitidine is going to oppose the action of sucralfate. Do we have an option of this meaning? Yes. Option number B. Look at option number B on your slide. Ranitidine inhibits the action of sucralfate. That will be the right option. Yes, I'm clicking it. You can see the answer on your slide. Ranitidine inhibits the action of sucralfate. So we completed the question number 10. Was it good? I hope it was good. It's going to work. And best of luck for your examinations. And do well. Thanks for listening. All the best.